All right, everyone. Good morning. Welcome. I think we're going to get started here in a second. So welcome to our third annual Kevin Graham Lecture in cardiovascular prevention. We started this lecture in 2018 to honor Dr. Graham. We're thankful that he's here today. He initiated our cardiovascular prevention program at Minneapolis Heart Institute, and so we wanted to honor him. And we've had great speakers in the past. In 2018, we had Phil Greenland. And then in 2019, we had Dari Mozafarian. 2020, we were forced to take a break, but we're excited to get started back up again. And similar to the past, we have a great speaker today. So we have Dr. Roger Blumenthal. He's the Kenneth J. Poland Professor of Cardiology at Johns Hopkins and the director of and the director of the Ciccarone Center for Cardiovascular Prevention at Johns Hopkins as well. He got his medical degree from Cornell and then did residency and fellowship at Johns Hopkins. He joined the faculty there and slowly over time has built the premier cardiovascular prevention program in the country and probably even the world. He's a highly successful researcher. He has over 600 publications. He's an excellent leader. I think that's what he's known for most. He's on multiple editorial boards. He was the recent co-chair of the primary prevention guidelines for the American Heart Association and the American College of Cardiology. He's been a mentor to multiple physicians who have gone on to successful careers in prevention. And he really excels in multiple roles. I know he's a big sports fan and he likes sports analogies. And so I'd say he's like a great quarterback and a great middle linebacker and a great coach kind of all wrapped in one. And so the Vikings could really use him. And so we're very excited that he's here today. So he's going to talk to us about the ABCs of cardiovascular prevention. Dr. Blumenthal.
Thanks so much, Mike. Well, folks, I have this mask here. It has a UA for Under Armour, since that's a Baltimore-based company, and I have the Hopkins Dome here. It's sort of a part of our contract that if we ever left town, we have to have that there. So I'm going to try to make things sort of light and lively here. If we're early in the morning, we're not brave enough in Baltimore to start grand rounds at 7 a.m. Ours is sort of 8 a.m. So I'm going to talk to you about sort of my way of thinking about prevention. And it was actually quite a number of years ago where I had the pleasure of talking to Kevin Graham at both ACC and AHA, and he was sharing with me his vision about a population-based approach to prevention. And I mentioned, I don't know if you remember this, Kevin, about sort of the ABC, simple as 1, 2, 3 approach, and talked about the Jackson 5 in Michael Jackson. And I think Kevin gave a smile and liked that one a lot when we were chatting. But I'm going to take you back on a little bit of a historical tour and put you into sort of the forefront of prevention like Mike has been. And Mike was one of our star contributors to the AHA-ACC primary prevention guidelines. This gentleman in the front there was Henry Ciccarone. He was a very close friend of mine, someone I admired very much. Sort of a mixture, let's say, of Bud Grant, Coach K, Bobby Knight, Vince Lombardi, Bill Belichick, all in one. He was sort of the premier person at Hopkins. Hopkins is known for the sport of lacrosse. He was also a great football star. And he died after his third heart attack at the age of 50. And this was back in November of 1988. Think back, the first statin was approved in 1987. Henry Ciccarone had metabolic syndrome, low HDL, high-stress job being a college coach. He guided Hopkins to 7 straight national championship games, won 3 of them. Probably those 1 and 2 goal losses of the 4 that he lost probably contributed a lot to his accelerated atherosclerosis. But it also looks like his assistant coach looks like he's more likely to punch the referee than Coach Ciccarone in that picture there. Great Hopkins, Maryland shot. So over the years, we've progressed, but we started off with a focus on prevention of atherosclerotic disease, coronary heart disease. But the same things that we try to emphasize lifestyle and medicine to lower the risk of heart attack, also lower the risk of heart failure, atrial fibrillation, and peripheral arterial disease. And here's some of the folks that Mike's collaborated with, Mike Blaha, Aaron Mikos, Bill McAvoy, Seth Martin, among others, Seamus Welton. And so our vision for prevention has grown quite a bit over the last 30 years. And now we have an even bigger team. Probably the most valuable person on our team is Dominique Ashen, a nurse practitioner, who's really been the glue of our clinical operation, because people will come to see the cardiologists, but what they really need is that reinforcement so much of the aggressive lifestyle modification. I applaud all of you who are part of the great team here, and Dominique Ashen and Dorothy Davis down here, who's a a nurse studying to be a nurse practitioner, really the glue of our operation. But we've added people like Karima Sharman, Women's Health, Kathy Wu, who's been an expert in MRI, Miguel Cainsos, Quorum Nasir, trained with us at Methodist, J.D. Patel, who Mike also just co-authored a paper in JAMA Cardiology, and a big interest in digital health with Francoise Marvel and Seth Martin. So let me take you back to the journey. So I was supposed to talk to these really smart Hopkins residents and try to explain all the guidelines to them. And I saw this paper that Ray Gibbons from Minnesota, Mayo Clinic, had. It was that weekend, and he talked about the ABCs of chronic stable angina. A for aspirin and antianginals, B for beta blocker, blood pressure, C for cholesterol, cigarettes, D for diet and weight, diabetes, E for education and exercise. And I thought, gosh, this is really the way we can teach the house staff and our patients about ways to keep in mind what the guidelines are and think about each and every visit, how are we progressing there? And one of the things that was talking about chronic stable angina, but as we have all learned with the ischemia trial and the COURAGE study, randomized trials still have not shown a survival benefit for revascularization in stable ischemic heart disease. You know, a lot of angina is due to these fibrotic plaques, and but you know, we can decrease symptoms with PCI, but the thing that we really want to try to do is to get pharmacologic stabilization of plaques, and this is probably one of the most famous micrographs of all time. This is the flowing blood, this is the cholesterol and plaque, but it also has tissue factor. This is the fibrous cap, and what Mike and many of you in the audience have always taught our trainees is that at the edges, the shoulder regions of the plaque is where sometimes you tend to get the destabilization. If that blood mixes in with the plaque, you get a stimulus for thrombosis. And so optimal medical and lifestyle therapy is really the key. And over time, in one of my favorite papers of last year was this one from one of our residents, Rick Ferraro, that talked about in stable angina that, you know, if providers and patients know what the anatomy is, many times they can do intensive medical and lifestyle management. And it's only certain subsets do we really have the data that revascularization is really so important. So over time, we've modified these ABCs into assessment of risk, antithrombotic therapy, which I think of as antiplatelet anticoagulant, B for blood pressure, C for cholesterol and cigarettes, D for diabetes prevention or management, diet and weight, and exercise and education. And when I type in my notes or when I speak to patients, I always try to do it in this ABC format. So let me go over a little bit of these primary prevention guidelines. And Mike was one of my star recruits. I was, going to say someone like Kirk Cousins or Gus Farad, but sometimes they haven't always made the smartest decisions. So Mike is more of, shall we say, a Tom Brady in training kind of person for the guidelines. So with a little bit more gray hair, he'll be right up there with TB12. So one of the things that Mike and I thought was the top 10 messages of our primary prevention guidelines was this statement: the most important way to prevent atherosclerotic vascular disease, heart failure, and atrial fibrillation is to promote a healthy lifestyle throughout life. And that was the overriding message that we had in our document that we did in 5 months. It was pretty darn amazing. We set a record for AHA-ACC guidelines. Now, if you think of that ABC format, A stands for assessment of risk. And one of the things we emphasized was shared decision-making. It's a team-based approach. Nurse practitioners, physician's assistants, pharmacists, people in cardiac rehabilitation. But it all comes down to using decision aids and presenting things to patients. They're the one that make the final choice. It's not so much we tell them what they have to do, but it's incumbent upon us to be able to present them with the right data. And one of the things we also stressed was the social determinants of health. And we emphasized to our trainees at Hopkins and our attendings, this 5-domain screening tool. Do our patients have safe housing? Can they get healthy food? Do they have trouble with transportation? Can they get to their medical appointments? They have money for utilities. And I think you need a little bit of heat in this part of the country here during the wintertime. And safety. Are you able to do exercise in your neighborhoods? So A stands for assessment of risk. And this is a nice slide by one of our fellows, Hamid Al-Fadag. And the ASCVD risk score is free. Everyone who's asymptomatic, it's class 1 indication. And there's something on there when you click on it, it says lifetime risk, but it's really a 30-year risk. And I think that's so helpful, as we'll talk about. We'll mention this risk-enhancing factors that Mike took the lead on with J.D. Patel, one of our new recruits at Hopkins, in this great paper. And then it took a nice journey over time, but there was so much more data about coronary artery calcium that we were able to elevate the strength of the recommendation to what we call a 2A indication. So what are these risk-enhancing factors? Well, a lot of it, a lot of us who trained a while back, we've been thinking of these. Family history of early heart disease, LDLs greater than 160, chronic kidney disease, metabolic syndrome or pre-diabetic state, conditions specific to women like preeclampsia, premature menopause. We also entered in chronic inflammatory conditions like rheumatoid arthritis, psoriasis, HIV, lupus. But as I'll show you, not everyone with these conditions is at high risk. And then we talked about South Asian ancestry, Native Americans having a greater predisposition to developing diabetes and early heart disease. We talked about higher triglycerides. So we want to think about that when there's uncertainty about our estimate for a person's risk of a heart attack or stroke. And it's really in that broad 5 to 20% 10-year risk category. So we said that in people at intermediate risk, if the decisions for preventive interventions like statin, maybe aspirin, maybe blood pressure remain uncertain, it's reasonable to measure a coronary calcium score. And we also talked about the importance of this 30-year risk estimate that we'll get to in just a second. Well, here's a nice example for you. You have a 32-year-old female, elevated cholesterol, low HDL for a woman, somewhat hypertensive, and she smokes. Her 30-year risk is about 40%. But you can also tell her that if she had optimal or normal risk factors, it would be about 1/5 of that. And hopefully that would be a motivating factor, and that's what all of you are trying to look for, more motivation to get our patients to make sustained lifestyle improvements. Well, I've always liked this cartoon here where the patient, where the doctor tells the patient, you're 57 years old, I'd like to get that down a bit. I wish that was that easy. But it emphasizes the point that age is one of the biggest determinants of what our risk is going to be. If you're less than 50 years of age, even with a good number of risk factors, it's really hard to be classified as a high-risk person. It's really hard to be classified as even an intermediate risk person. And for a woman less than 65, it's pretty rare, unless she's a smoker or has diabetes, that she actually gets into that range where she's eligible for statin therapy. So our group was one of the early adopters of coronary artery calcium, and Dr. Miedema has been working with our group for a long time on this coronary artery calcium consortium that Mike Blaha has led. And one of the things we've always talked about is the different lesions in atherosclerosis. And there's this type 5 fibroadenoma where you have calcification is already deposited there. And by that time, you know that that person already has a lot of atherosclerosis. So that white stuff is the same color as their sternum, their ribs, and this is a lot of calcification, the LAD diagonal, and circumflex. And coronary calcium is subclinical atherosclerosis. And the most important publication from our MESA study way back in 2008, the world was a lot different in 2008, was that a calcium score of 300 or higher was associated with about a 10-fold higher coronary heart disease risk for a person the same age who had no coronary calcium. So that's what really got our attention and started slowly getting the guideline attention. So I always cite this paper as the origin of the power of zero. Mike Blaha was the first author, and he did this worked on this when he was a fellow and at the end of his residency. And we had this data set of 44,000 people, mainly people in their 60s who had coronary artery calcium scoring. And what Mike found was that the absence of calcium predicts excellent survival with a 10-year mortality rate of just 1%. So Mike postulated early on with Khorram Nasser that a finding of zero coronary calcium might be used as a rationale to emphasize lifestyle therapies rather than jumping right away to statin, aspirin, maybe blood pressure medicines, and to forego repeated imaging studies, sort of that atypical squirrely chest pain where, it may take $1,500, $2,000 for a stress nuclear test. And that was the paper that we generally say is the origin of the power of zero. And this is a picture of Mike and Khorram Nasser and Matt Budoff, and the four of us did this paper talking about a Bayesian approach, that a zero coronary calcium score is very reassuring in people who are asymptomatic, but if they come to Abbott Northwestern with chest pain, sweating, pain down their arm, and they said, "Doc, I had a calcium score of 0 6 years ago," you have to rule them out for the MI, the standard thing. But if they're asymptomatic, as you'll see, it's very reassuring. So when I presented the summary of our American Heart Association cholesterol guidelines in Chicago in 2018, seems like a lifetime ago, I said that coronary calcium is the best tiebreaker if there's uncertainty. And for many clinicians and patients, there's always uncertainty about their risk is, because the ASCVD risk score is really just an educated guess. It's not that precise at all. We talked about personalization, identifying a very low-risk group if people had no coronary calcium. I tried to emphasize it's a decision aid and not a screening tool. It's not something that we'll do throughout all of Minneapolis and St. Paul, but we want to try to focus treatment on those who will benefit the most. So when do I personally consider a coronary calcium score? Well, if they're in that broad 5 to 20% 10-year risk, they're reluctant to go on a statin, maybe they're intolerant of their first statin, maybe, their numbers are still high, and whether we're trying to add ezetimibe, et cetera. But mainly it's people who want to know, "Doc, do I take after my aunt who had a triple bypass at age 52, or do I take after my uncles who lived into their 90s, et cetera?" And trying to figure that out. It's just like if someone has a family history of osteoporosis and hip fractures, I can't tell by looking at them if they're at high risk. I need a bone density scan. And for coronary risk stratification, the best tool we have is a coronary calcium scan. So let me direct you to this slide. This is LDLs. This is 3.35 millimoles per liter. Think of about 160 milligrams per deciliter. And what Seth Martin showed is that you could have a really high LDL, but if you had no coronary calcium, your risk was pretty darn low. You could have a really low LDL, but if you had a calcium score greater than 100 and had moderate coronary calcium, your risk was almost 9 times higher. And this was a great paper led by Mike Blaha that showed that if this is the pre-test probability, post-test probability, here it's equal. But if you had no coronary calcium, your risk goes down by 60 to 70%. It's more reassuring in someone who's, say, 55 and older, less reassuring in the younger groups where it's 45 to 50, partly because maybe they just haven't had time to calcify their existing plaque. Well, I often ask the trainees, do you know what the difference is between Framingham risk score and the ASCVD risk score? And most of the time they don't know. And I try to emphasize that ASCVD talks about fatal or non-fatal MI or stroke. And I could tell a person that they have a 15% risk of a heart attack or stroke. If they say they're 50 years of old over the next 10 years, I think that's high. And they may say, "Oh, 85% chance I'm fine, doc." And that's not what I want them to think about. But if I remind them that this ASCVD risk score doesn't include revascularization, doesn't include bypass angioplasty, doesn't include heart failure atrial fibrillation, if you used more of a global composite CVD risk score, that 15% risk of a heart attack or stroke may be actually a 50% 10-year risk. And I'm hoping that we'll have better risk stratifying tools and help us with patient communication. So this is a paper that Mike was a key contributor to with J.D. Patel, and I just want to show you this paper and direct you up. And here we talked about risk-enhancing factors. So things about high LDL, high triglyceride, metabolic syndrome, things. If you had no coronary calcium and you had 3 or 4 risk-enhancing factors, your 10-year risk in the MESA cohort was significantly below that 7.5%. It was about 5%. So coronary calcium still trumps risk-enhancing factors. I personally try to tell people if they have multiple risk-enhancing factors, their long-term risk is high. Maybe it's their 15 to 20-year risk, but having that no coronary calcium portends somewhat of a lower 10-year risk. So the other way to look at it is that pooled cohort equation is a broad estimate. If they don't have risk-enhancing factors, it moves it further to the left. But if they have no coronary calcium, it's way to the left. You can't tell a person they have zero risk, but the risk may very well be 1 or 2% over the next 10 years. And I think that's very helpful in patient communication. And I try to tell people, you want to prevent the development of fibrotic calcified disease. And you really want to actually rev up your lifestyle habits to try to prevent you from developing that atherosclerosis. So over time, we've also used coronary calcium for other things. We know that for statins, you could say the most cost-effective thing is to give everybody a statin. Be great for the Allina Health system. Maybe by age 50, if they didn't have side effects, it'd be great. But nowadays, you guys are dealing with high-cost items. So Chris, icosapent ethyl, really high cost. PCSK9 inhibitors, GLP-1 receptor agonists, SGLT2 receptor agonists. Where a lot of our research has been going is that if you identify high-risk primary prevention with advanced subclinical atherosclerosis, we're more likely to prescribe those higher cost items. And I think that has implications for the sustainability of the healthcare systems. In contrast, if they have no coronary calcium, probably harder to justify those more expensive items. Well, let's shift to a topic that Dr. Meadham has written a lot about, antiplatelet therapy, one of our favorite cartoons here where the doc tells the patient, to prevent a heart attack, take 1 aspirin a day, take it out for a jog, then take it to the gym, then take it for a bike ride. Those things work. After all these years, we still don't know how effective aspirin is. So what did Mike and company put down for our guidelines? We said we gave it the weakest recommendation possible, 2B. Low-dose aspirin might be considered among select adults 40 to 70 at higher risk, but not at increased breathing risk. And we gave it a class 3 harm recommendation in primary prevention for adults over 70 in primary prevention. And we also gave it a class 3 don't use if they're at increased risk of bleeding. And that's different than the guidelines when a lot of us in the audience who have a little gray hair like I do trained, because back in 1997 and 2002, our guidelines gave a class 1 strong indication for aspirin to be used in adults at intermediate risk. And we defined intermediate risk as a 10-year risk of a heart attack of at least 10%. So what changed? Well, back in 2014, there was this big meta-analysis that said aspirin could decrease cardiovascular events by 10%, but bleeding events went up by about 50%. So the number needed to treat to prevent one major event over a follow-up of 7 years was about 280. The number needed to harm for a major bleed was about 300. So let's see here if I can advance. All right. So this was a great collaborative paper that Mike led, had Mike Blaha in here and Aaron Folsom, who's also from Minnesota, who I think is maybe listening in today. And what they did in this article was a great modeling experiment, was to think about the 5-year number needed to treat estimates and try to say if you assumed about an 18% relative coronary heart disease risk with aspirin, are there some people who you might consider for aspirin? And what Mike and company did was to say, well, if their 10-year risk was at least 10%, the number needed to treat if they had no coronary calcium was about 800. Clearly not cost effective. But if they had moderate coronary calcium, it was below 100. So in the general population, Mike's study said coronary calcium may be a useful guide to a more personalized, safer allocation of aspirin. And that's really the heart of preventive cardiology, trying to personalize the data. Now in 2018, we had a series of aspirin studies. This one called ARRIVE showed no difference between aspirin and placebo. The ESPRIT trial looked at people over the age of 70 in primary prevention for the most part. And all-cause mortality actually was higher in the aspirin group. And surprisingly, cancer deaths in the New England Journal, where this was published, was also higher. We always used to think that aspirin would decrease GI cancers, colon cancers, but that's not what the studies in 2018 showed. And there was no benefit on dementia or on physical disability. The ASCEND trial in diabetics showed a 12% decrease in cardiovascular events, but nearly a 30% increase in bleeding events. So that was a wash, and the ASCEND was done in diabetic patients. And then Mike worked with us as second author on this key paper with Miguel Cain-Sosa Achirica, and this was a really nice paper. And if I can just direct your attention here to the broad intermediate risk category of 5 to 20%, the number needed to harm was about 230, but if they had a real high calcium score, the number needed to treat was below 100. So they concluded that, again, some look at the amount of subclinical atherosclerosis could help us with that aspirin question. And then subsequently, a study from the Dallas Heart Study looked at a subgroup of people at lower bleeding risk, and they also had the same conclusions that Mike found, that if they had a calcium score greater than 100, they could lower the ASCVD risk a little bit more than the major bleeding risk went up. So again, this attempt that we're all trying to do with personalized medication. So we've gotten through assessment. We've gotten through antiplatelet therapy. Let's go B for blood pressure. And remember, normal is not 140/90. Normal is less than 120 and less than 80. And that's so important, and most of our trainees don't realize that. Now, keep in mind that the original blood pressure guidelines that I helped to pick the panel for said you wouldn't even think about drug treatment unless you're 140/90 if your 10-year ASCVD risk was 10%. But if you had a high estimated risk or diabetes or chronic kidney disease, you start thinking about medical therapy if your blood pressure is greater than 130/80. I usually tell people blood pressure is pretty straightforward. Weight loss, healthier diet, reduce your sodium, increase dietary potassium, increase physical activity, cut back on alcohol. Little humor for you here. I told Mike about this. So my son is a goaltender, Division I athlete. He stands in front of 100-mile-per-hour lacrosse shots. And he and his team was wildly successful, went to the NCAA tournament last year. This is a great pandemic picture. This is yours truly, pulling down my Under Armour mask, voicing my displeasure with 4 lousy calls in favor of Notre Dame and against my son's Drexel team. My wife is very calm right there. This is Dr. Wendy Post. And this gentleman, I think, told me later this is the Italian salute he was trying to direct at the referee. Maybe they do that at Vikings games. I'm not exactly sure. But remember, when you think about measuring blood pressure, you want to avoid those unnecessary stressors. Let's go see cholesterol. So probably the paper I was most proud of in the last few years was this one Aaron Mikos, Bill McAvoy, and I did in the New England Journal. And for those of you greater interest in personalized medication as relates to cholesterol and atherosclerosis management, this is a great paper where we talked about healthy lifestyle for everyone throughout the Twin Cities, New Ulm, Baltimore, wherever. It's shared decision making. We measure risk factors. We estimate a person's risk. It's pretty easy if they have clinical atherosclerotic disease. We're going to be really aggressive. It's pretty easy if they have super high LDL or if they have diabetes. It's a little more thinking when we're in that primary prevention 7% range or higher. So when in Chicago, when we presented this, I also said the conclusion of our studies were low LDL is better with proven therapies. You want to use a high-intensity statin, get at least a 50% drop. We brought back numbers, threshold of 70 for non-statins, and we said for cost reasons, think ezetimibe first, PCSK9 second. For people with familial hypercholesterolemia or primary severe hyperlipidemia, because their lifetime risk was so high and they've had it for long, we said try to get down that LDL less than 100. And the Friedewald equation has a lot of imperfections in it, and Seth Martin and Steve Jones developed a different estimate of the LDL equation called the Martin-Hopkins equation, and that has a lot of advantages. So what about these very high-risk people that here in the Twin Cities, they come in for their bypass surgery or multivessel PCI after acute coronary syndrome? Well, we said it's reasonable to add ezetimibe to the maximally tolerated statin if the LDL remained above 70. And we said that at the time, we had questions about the cost effectiveness of PCSK9 inhibitors. And after we put that in the guidelines, probably in the next 6 months, the companies dropped their price by half. And I think that was a good thing. So what's the data about ezetimibe? Well, we usually point to this 2015 study called Improve It, where there was just about a 7% relative risk reduction. But one of the things that I often tell people is look at these numbers here, 35% and 33%, really high numbers at that 6-year mark. And the people who benefited the most by ezetimibe were the ones in the high-risk category. They had 3 of these TIMI risk score factors or more: history of heart failure, hypertension, older age, diabetes, prior stroke, bypass, PAD, low GFR, or smoking. They had an absolute risk reduction of nearly 6.5%. So when you're thinking ezetimibe, it's definitely the data is really there in the higher risk people. Well, what do you need to know about the PCSK9 inhibitors other than they're really expensive? Well, a lot of us thought it might be like Drano when we first thought, 60% LDL reduction on top of what you already were there, but we haven't seen that. So in Fourier, basically comparing an LDL of 90 to 30, it was a 15% relative risk reduction. To be honest, the outcome was a little bit trickier to interpret. Initially, it was basically 90 versus 30, but because some of the people got their LDLs down too low, they cut back on the lipid lowering intensity, and they also came up with about a 15% relative risk reduction. So it's tricky for healthcare systems trying to decide, but clearly the data is best in secondary prevention. Well, about 9 months after our AHA-ACC guidelines came out, the European guidelines came out and they were even more aggressive. So what do you need to know about them? Well, they took 55 milligrams per deciliter. They said if you had 50% carotid stenosis or 50% coronary stenosis on CT angiogram, you might as well get their LDL down below 55. And they even said if you've had a second event within 2 years, you might as well target an LDL less than 40. So they're even more aggressive, and they had less focus on the cost effectiveness. Now, I've been in this business a long time, as some of you in the audience have been too. And it's interesting, I was an interventional cardiology fellow when 4S came out. And when you think about it, that was the first one that showed a decrease in all-cause mortality. But, the baseline LDL was close to 190, and it got down to about 125. And now with the PCSK9 inhibitors, we're getting that LDL on treatment down to about 30. And it's been pretty consistent over the years, and I've always liked this nice figure that Eugene Brunwald came up with. But you've noticed I haven't talked about sort of what, if you had invite Deepak Bhatt next year, brilliant guy, one of my closest friends. He didn't quite like the editorial that Garima Sharma and Seth Martin and I wrote about his, it was about the strength trial, but we compared it to the Reduce It study. So Reduce It, just to refresh your memory, age at least 45, established cardiovascular disease or diabetes with one other risk factor, triglycerides between 150 and 500. Well, what did it show? Well, it showed about a 25% decrease in events, and for second events, it was about a 30% decrease in risk. Now, the data was the strongest in the secondary prevention cohort, 26% versus 19%, stronger than just in the primary prevention diabetics, which was 13.5 versus 12%. But the strength trial also looked at high-dose EPA, but it also included DHA, and that didn't show a benefit. So when we wrote our editorial for JAMA, we talked about, well, maybe it was somewhat, the results of Reduce It were exaggerated somewhat by the comparator they picked, the mineral oil. Mineral oil was associated with an increase in high-sensitivity CRP by a third. LDLs went up by 11%. So in my heart of hearts, I think high-dose EPA is useful. I just don't know if the benefit is as great as what my fellow New England Patriot fans at the Brigham seem to think. But we'll see what happens. Well, what are the other thing you need to know about the cholesterol? Lp(a), we've been talking about that emerging risk factor for a couple decades. And this was a paper my wife, Dr. Wendy Post, was a senior author on that showed that high Lp(a) was also associated with vascular calcification and aortic stenosis. But we still don't know for sure how to approach our patients other than to be really aggressive with lifestyle and medical management. Ron Blankstein summarized the field pretty well that, we arbitrarily say a high Lp(a) is in the top 20 percentile. We think it's atherogenic and pro-inflammatory and pro-thrombotic. We have a number of agents that are under investigation. I think you all are looking at some of them here at Minneapolis Heart Institute. But for right now, all we have to say is that you want to be aggressive with LDL and the things you can control. Well, folks, we're heading into the home stretch. C for cigarettes. What did Mike and I write about primary prevention? We said nicotine replacement in one of these forms, plus either bupropion or varenicline. D for diet. Well, Eugenia Gianos gave me this slide, and I really like it. I try to tell patients that if you can be at this end of the spectrum, more fruits, vegetables, legumes, whole grains, and not so much at some of where those fans are at some of the Packer and Viking games where they have all this red and processed meats in their diet, and they take their shirts off in this cold weather, and we think on the East Coast, what are these guys doing? This is associated at this end with a lot more atherosclerotic vascular disease. So as Eugenia said, you want to eat more of this, fruits, vegetables, whole grains, legumes, and less of the red meats and processed meats, less of the sweets, less of the sodium. So that's the message for all the population-based studies and for our individual patients. And the way Mike and I codified this, we said, emphasize the intake of vegetables, fruits, legumes, nuts, whole grains, and fish. Cut back on saturated fat. Cut back on dietary cholesterol and dietary sodium. We want to minimize the processed meats. Think bacon, sausage, refined carbohydrates, sweetened beverages, and try to minimize your intake of trans fatty acids. Time for a little humor for you. For those of you who don't have coffee right now, you need a little humor. Patient comes down middle of the night. Spouse has already padlocked the door. Newspaper says 6 of 10 Americans overweight. This is the latest in Homeland Security. That might be a pretty good way for time-restricted eating. That's you want to make sure you're not getting those late-night snacks. But that's the thing all of us in this room struggle with for ourselves, our family members, our patients, and hopefully we'll make some good advances in that. So I often talk to patients who have hypertension about the salty 6, breads, rolls, pizza, sandwiches with white bread, cold cuts, cured meat, typical soups, burritos, tacos. If you guys could cut down on your patient's intake of those, you wouldn't have as much hypertension and strokes in the healthcare system. Well, D for diet, we're almost finished. Said monitor weight, measure waist circumference, because waist circumference is one of the criteria of the metabolic syndrome and BMI. Aim for, set a goal of at least 5% of body weight. We want to increase physical activity to a minimum of 150 minutes of brisk activity, but we always emphasize that 200 or more is better. And we want to have people get some idea of the caloric intake and maybe initially reduce their intake by 300 calories a day, but probably if they're significantly overweight, it's going to be higher. So for diabetes, it wasn't just A1C and glucose. We talked about the importance of a tailored comprehensive nutrition plan, increased exercise, and goals not only for A1C, but also for weight and exercise. We took the tack that we would still favor metformin in primary prevention because the best data with the GLP-1 receptor agonists showed a relative risk reduction of about 10 to 12%, and the number needed to treat was still pretty high. But for people with multiple risk factors or who have already had an event, clearly the data with SGLT2 inhibitors and GLP-1 receptor agonists are so important. Well, D for diabetes. People with diabetes are a heterogeneous group. If they have no coronary calcium, we're going to approach them differently than if they have a high coronary calcium, where we may take Mike's lead about aspirin. We may be thinking about the more expensive cardiometabolic treatments because those people have a risk comparable to traditional secondary prevention. Now, maybe imaging might help us. The use of a coronary calcium score 0 to de-risk patients with diabetes is not currently recommended, but if a patient is not inclined to go on a statin and hasn't had diabetes for that long and their A1C isn't that high, you can certainly say, let's see if we redouble your efforts at better lifestyle habits, maybe we can change that A1C from 7.2 to 6.2 over the next year. You're more likely to use the more expensive medications than the people with the higher amounts of subclinical atherosclerosis. And you're more likely to be more aggressive in the lipid management, and you're more likely to consider aspirin if you knew they had a high coronary calcium score. So E for exercise. It's amazing when I show this to some of our residents in Hopkins, and they're not sure who these two guys are. And I say, Michael and Michael. So exercise, what we tried to put in our guidelines, basketball, shooting around, dance. I think Michael Jackson did a pretty good job there. And remember, we got the ABC idea from ABC, simple as 1, 2, 3. So we have to emphasize to our patients, exercise comes in many forms. And clearly the greatest benefit is when you go from being sedentary to some exercise. But more and more exercise is certainly beneficial. And then we've added recently F for heart failure. And this is from Greg Fonaro's work where, with each intervention, whether it's an ARNI like sacubitril valsartan, beta blocker, aldosterone antagonist, SGLT2 inhibitors, your relative risk reduction now in patients with newly diagnosed HFrEF is substantial. And your number needed to treat to decrease a major event is now down to 4. So keep that in mind for all the cardiomyopathy specialists, and all of us have patients with heart failure. And then the data with the SGLT2 inhibitors, starting with this EMPA-REG study, was just so impressive, where we learned that you could actually decrease cardiovascular events. It wasn't just neutral, is what we were hoping initially, that they wouldn't have harm. But now we have such a greater emphasis on the SGLT2 inhibitors and GLP-1 receptor agonists. And Seth Baum, at a recent symposium, talked about how the SGLT2 inhibitors and GLP-1 receptor agonist trials have demonstrated risk reduction and really changed our focus. And clearly the SGLT2 inhibitors you think of to try to decrease heart failure hospitalizations, new onset heart failure, and progressions of chronic kidney disease. And Chadian Dumoulin and Justin Achufo have sort of led some of our epidemiologic work where it says the longer you've had diabetes, the higher your risk of heart failure. We have to stress that to our patients when they get that initial diagnosis of diabetes, that they may not have a cardiac event right away, but if we don't make substantial improvements, they're destined to have a lot of problems. So folks, this is sort of the way I approach patients, and this is the way I tell our residents. A, antiplatelet therapy, is it single or dual? A, for anticoagulant therapy, do they qualify for a NOAC or warfarin? B, for beta blocker, do they have a strong indication? Do they have heart failure if they had a recent MI? B, for blood pressure. C, for cholesterol, cigarettes. D, for diet and weight guidance. D, for diabetes prevention or management. Emphasis on the newer, more expensive agents and trying to decide when to do it. Probably the most important thing I try to get patients to do is think about lifestyle, and E for exercise. Then you got to add that F for heart failure. And now we have so many other things to keep in mind, and maybe our EPIC systems and things like that can help us and also educate the patients about what are the key things. I don't know how many of you are familiar with CardioNerds, but that's a group of cardiology fellows, and they've done some great podcasts, and they've sort of modified the ABC approach. You always get the younger folks to come up with better things. They think about A, for assess the risk and anticoagulation, B, for BMI and blood pressure, C, for cigarettes and cholesterol, D, for diet in terms of sleep apnea and good quality sleep, and diabetes, E, for exercise, and F, for failure. And I think, like all ideas, there'll be modifications. So I'm going to leave you with this next to last slide of one of my favorites. It was put together by Aaron Mikos, our Associate Director of Preventive Cardiology. And again, I remember we had our roots in lacrosse. This is the Hopkins Blue Jay with a lacrosse stick, stethoscope, headlamp. And remember, the AHA always likes to say life simple 7. I think ABC. So I think B for blood pressure, C for cholesterol and cigarettes, D for diet and weight, diabetes prevention, and E for exercise. So it's been a long and fun journey, and our preventive cardiology program has been in existence for now 30 years. And it's great to be able to work with people like Mike and others you here at the Minneapolis Heart Institute. And thanks for inviting me to come, and thanks to Kevin for all the great work that he's done, a true visionary in the field of prevention, and happy to take any questions. So thank you very much for your attention. So folks, first person to ask a question gets a prize. Is that right, Mike?
Big prize. Questions?
With all the data that you discussed about coronary calcification, it still is largely non-reimbursed. Why do you think that is? Is that sort of a hangover from when it first came out, when people were very skeptical?
Great question. So the question relates to, like some tests, like a colonoscopy, patient doesn't have to pay for it. That's, what we do routinely. And so in Baltimore, we charge $75 for a coronary calcium scan. We tell patients that some insurances pay for it, some don't. I think Mike said many times patients here might pay like $99, something of that nature. And I usually tell people that, insurance companies aren't in the business of trying to figure out more things they want to pay for. And over the years, as you can imagine, I've written lots of letters over the time of patients where it's clearly changed the management and to their insurance companies. And some, like the Blue Cross Blue Shield, now are much more apt to pay for it once you explain it to them. But you're right, when coronary calcium first came out, especially in places like Chicago, billboards up, commercials, this is get your loved one or spouse a coronary calcium scan for Valentine's Day, make sure they're going to be alive and things of that nature. But over time, the science is much greater. And so that is a drawback. But for many patients, when you think about what the cost is of a blood pressure medicine or a cholesterol medicine, if they're on the fence, they'll say, sure, I'll pay the $75 to $100. But it is a challenge, I agree. Other questions?
If I could follow up on Mike's question, and by the way, that was a very good talk.
Thanks,
you.
Scott.
Why do you not support coronary artery calcium as a screening tool? Sort of like, I guess, breast cancer
Sure.
mammography would be an analogy. What's your perspective on that?
So great question. So the question is, what about coronary artery calcium as a screening tool? So I guess part of it is, you have a higher bar for a screening test. With mammography, there had been studies showing that you can decrease subsequent events and decrease subsequent costs. And we still haven't had the compelling randomized controlled trials to satisfy everyone that we have that for coronary calcium. And I think, probably those of us in the audience that have been in the business for a while would say, for our patients, we'd actually like them to have their cholesterol numbers lowered quite a bit when they're 50 or 55 or 60. So I don't actually order many coronary calcium scans. I sort of try to show them what their 30-year risk is and say, it's pretty easy for us to control that. What I need to spend more time on my clinic visit with you is going over more about diet, weight, and exercise. But I think, there's a couple ongoing studies that may push the bar enough that we'll revisit with that with some of the large payers. But right now, I think Decision 8 is a lower bar. It's not a Class 1 indication. Everyone has to have it. But it's a Class 2A. And I think I look at it as a good tiebreaker. So stay tuned with some of the ongoing studies to see if they'll be compelling or not. But right now, I think Class 2A I'm fine with. Other questions? So,
Great talk and overview of the topic. I'd like to hear your thoughts on the recent data on the salt substitutes that came out from China at ESC.
sure.
How can we implement that? Is that impactful as a primary prevention strategy?
Great question. It deals with sort of the controversies that some people have had. There's a small minority of people that haven't bought into the fact that, when you have moderate to higher amounts of salt in the diet, your blood pressure goes up, your stroke and heart attack risk goes up. And Paul Welton, who was the principal investigator for the SPRINT trial, has been one of the more eloquent defenders of the sodium hypothesis. And this more recent data is also very, very compelling. And with the SPRINT trial, just to refresh people's memory, we were comparing systolic blood pressure of around 120 versus a systolic blood pressure below 140, and the average was around 133, 134. And that showed a 25% decrease in events and also a decrease in all-cause mortality. But what you'll see at the upcoming AHA meeting is even a greater impact on heart failure. And I think it just adds to the evidence that we really want to pay attention to sodium intake. And I'll look forward to sort of seeing what the ramifications are from this recent New England Journal publication. But remember that AHA Salty 6, and when you see those folks tailgating at the Vikings games or maybe the Gopher games, you might tell them to cut back on the sodium that they're eating in some of those foods. Other questions? Yes, sir.
Thanks for this talk. It was great. Just kind of a hypothetical. If you have two 50-year-olds had their calcium score, one is 0 and one's a several hundred, do we have any serial imaging data like 20 years later? What happens to does it widen the difference, or are you just someone at 50 just delays their risk and they accumulate calcium later on in life?
Great question. So Mike Blaha is our established MJ23 of preventive cardiology. And he's someone who we all try to emulate. But what Mike recently published was a really provocative piece in one of the JACC companion journals. And basically, let's say you actually, and Mike's been involved with some of this work about coronary calcium in younger individuals, people 40 and younger. So if you're someone who has some coronary calcium, let's say between 35 and 40, let's say score of 1 to 10. By age 50, your coronary calcium score on average is up to 100. By age 60, 10 years later, it goes from 100 to 400. And by age 70, it's 1,000. So it's this accelerated rate of increase. And I think, some people think, well, I was 42 years old, I had a calcium score of 20, they said it was mild, but they forget what their percentile is. And what we've learned, and Mike can talk to you more about that in a different conference, is you usually stay in that same percentile. So having a high percentile when you're young is a poor prognostic indication. Now, if you have two brothers, maybe one took after one side of the family and the other took after the other side of the family, it's hard to know for their cardiovascular risk. But we see that a lot, and especially large families where there may be some people who have a really high score for their age and other siblings who have no or minimal coronary calcium. But over time, it goes up exponentially, the calcium scores. So that person who had a calcium score of 0 may or may not start having mild coronary calcium by the time they're 65 or 70. And the current thinking is that if you have no coronary calcium, you would potentially, and you're not on a statin, you might rethink that in sort of that 5 to 10 year mark of a repeat scan. Other questions, comments? Anything about Kirk Cousins I can answer for you?
What about diabetes? We have pretty compelling evidence for the SGLT2s and for the GLP receptor agonists. Yet we've seen kind of slow uptake from cardiologists in prescribing them. They're kind of a little bit hesitant to kind of get back into the realm of diabetes because for quite a while we were kind of out of that realm. How do you guys handle that at Hopkins, and do you kind of see kind of a similar thing?
So great question, Mike. I think we've established a sort of a cardiometabolic clinic that for the cardiologists who are trying to decide about a SGLT2 or GLP-1 especially, that they can refer to this cardiometabolic clinic. We have Dorothy Davis, who's a great nurse health educator, Kunal Jha, one of our senior fellows, Mike Blaha, and several other attendings. So many patients are interested in the GLP-1s, partly because of the data with semaglutide and other things about weight loss. And that's how, and clinicians are also interested in something to help their patients with weight loss in addition for better glycemic control. So that's one way we've approached things for the clinicians who have been somewhat hesitant to think about some of those things. And but I think as time goes on, hopefully all of us in this room will really be prescribing more of those things, or at least educating our patients about that opportunity. Any other questions? John?
I have a few online questions. First of all, thank you for your presentation. That was excellent. The first question is, can lifestyle reverse coronary atherosclerosis?
Great question. So I think Kevin Graham and I may have talked about that 15, 20 years ago on a panel at AHA. But so I usually tell people we don't have Drano. We can't really clear out those rusted pipes completely. But many times we can stabilize, sometimes get some modest reversal. Dean Ornish showed back in the late 80s in an aggressive what he called the lifestyle heart study, that you could get some modest decrease in coronary artery diameter and improve myocardial perfusion. So we've known for a long time you can get some modest decrease, but you can't really get rid of all the atherosclerosis. And I think now when I think about preventive cardiology, we're focused so much on lifestyle and optimal use of guideline-directed medical therapy. So I'd sort of like to have sort of guideline-directed medical and lifestyle therapy. That's what I think sometimes all of us in busy practices where we're told, you have 15 minutes for a patient or 20 minutes for a patient or things like that. It's hard to get across everything that we want to do that is going to save the health system money long term. Any other
Yeah,
questions?
there's just one more online question. It says, fantastic presentation, first of all. The question is, statins increase calcium score. Would you ever use a high calcium score on someone who has already been on long-term statins to decide whether to use aspirin or not for primary prevention?
Great question. So the issue about aspirin, we may give that one to Mike in just a second. But I think, while we have data that Mike and others have published on when you have calcium scores that are high in that 400 range, it's certainly a secondary prevention level of risk. And I think it's as long as they don't have any real factors that would increase their risk for stomach upset or GI bleeding, I think a lot of us would strongly consider aspirin. I don't like to repeat a coronary calcium scan or do one in someone I know has atherosclerotic disease unless they're in a clinical trial. So, or if it's going to change management. And so, one of the reasons I don't order many coronary calcium scans is that 1 in 30 to 50 people are going to have one of these. If they're non-smoker, will have a nodule. The radiologist will say, it's 6.5 millimeters. Probably nothing, but I need to get a full chest CT in 6 months. And a lot of patients, what happened to us or happened to our patients, they get pretty concerned about the risk of cancer or some other inflammatory condition. So I try to be very selective in who I get a coronary calcium scan on. So personally, I would say no. Mike, what's your thoughts about
Yeah,
aspirin?
so the data for statin and calcium progression, it comes from a trial in the 90s. The title of it's blanking on me right now, but there was a couple asteroid studies looking at plaque regression via IVUS. So when you ultrasound the plaques after people lower their LDL, the plaques get smaller. Plaque volume clearly goes down. And that's mainly from a reduction in soft plaque and inflammatory plaque. The calcified shell of the plaque never goes away. And so the other company that funded plaque regression did it by following the calcium score, and it backfired because scores actually go up a little bit because you make the calcified shell more dense. And so it's not a market elevation. And so if somebody comes with a calcium score of 800, it's like, the 700 has to do with the statin that they took. That's not the way to think about it. It just does slightly increase calcification. So I wouldn't change my decision-making based on the fact they've been on long-term statin therapy. And so if their score is above 400, I think that's where that shared decision-making comes in. If they're at low bleeding risk and they do everything they can to reduce the risk, I think a baby aspirin is pretty reasonable. If they're older and frailer, I tend to be less likely to do it.
Thank you.
Well, folks, thank you very much for your attention. Look forward to seeing some of you later on, and have a good rest of the day.